Darla Peterson. Were you here a couple months ago when I talked about syphilis? Yes, some of you? Okay. So today I was going to concentrate on HIV and some of the facts and some of the information that we have, some stats. And so I have been with the Bureau of HIV, STI, and Hepatitis for about 9 years. But I have 32 years of experience in the field of HIV, STI, and hepatitis. I manage the HIV program in Sioux City, where I reside, for most of that time. So let's get started, and I'll show you some things. And stop me along the way if you have any questions. I am a regional health specialist, and so we are presenting information to folks like you, and also to mental health providers and substance use providers, sheriffs. I talk to them, and a lot of community meetings as well, so that we can talk about how to best eliminate HIV, and we're working towards impacting STIs as well. And then stigma, so we're really addressing stigma in Iowa as well. So our mission is to cultivate the workforce that will end HIV, STI, and hepatitis-related health disparities. So we're hoping for your help. And we started this work in 2016. And I was going to show this video because one of the exciting things is when we first started this program, it was because of the fact that patients living with HIV asked for this program. They asked for people to go out to the rural communities especially and talk about HIV and all the things that we can do today to prevent it. And so I like to start with them. And we did ask them to do some videos. They meet. There's a group called PITCH, Positive Iowans Taking Charge. And we actually went to the Wellness Summit last year, and we got some brave souls to do some videos. So I was going to show you one of those today because it's pretty powerful to be able to hear from them. You know, I've been doing this enough times that I've got in my head years and years of patients, what things that they've said and testimonials, but you know, to have them actually say it to you and tell you how important it is to be listened to. The lady that's in this video was talking about how she just wants to be listened to, whether it's about her past drug use or other things, but you know, not to be judged. So it's exciting that we have those, but for some reason it's just not working here, so I'm going to skip that. So folks that didn't want to do a video did a mask, some of them, or they just sent some quotes along. And so I've got this mask that someone made, and it says, "Life is a dichotomy for all." This is especially true for long-term HIV survivors. The contrast between 1985 and 2025 is immeasurable. So on his mask, he has 1985 on one side, throwing up, diarrhea, death, and then on the 2025 side, he has acceptance, love, life, because he's doing well now, and there's a lot of difference. So I thought that was kind of a cool one. Well, we talk about stigma, but I like bringing a patient voice with me before I get started. And so here's our map. You can see I'm Region 1, so I have 22 counties in Western Iowa that I go out and talk to, and there's 5 of us in the state that are doing this work. And so we match the National HIV/AIDS strategy because we're trying to get people diagnosed with HIV, get them into care as quickly as possible, then keep them in care so that we prevent new infections. We'll talk more about how to do that. And then responding quickly if there's any clusters of new cases. We have folks that are working on that. So we want to end the epidemic, and every state is working towards that, but it's going to be really difficult without ending or really working on STIs. We can't end STIs, but we can impact them. And so the higher incidence there are of STIs, then sometimes the HIV transmission goes up. And I was here a couple of months ago to talk about syphilis because that's one of the huge problems in our state right now. Is we don't know why, but there's a lot of people with syphilis. And so we want to think about that. I always just show this. I know you know this, and I'm sure you know that too. And I like to just put a little humor into it. I used to have people, when I used to do testing myself, I used to conduct testing, and some people would say, "I got it from the toilet seat. It was dirty at work." It's not TST, folks. It's not toilet seat transmitted. So people can tell you this, but it's not true. And then I like to talk about language because it's really important. You know, language has changed over time. We used to say HIV positives and you know, drug addicts and clean and dirty, things like that. And so it's really good today to talk more with person-first language. And so you can see some things there. I'm going to point out a couple of them on this one. So like I said, HIV infected person, now we're saying people living with HIV, kinder, gentler. And then, it's not an AIDS test anyway, it's an HIV test. So if somebody says, I want an AIDS test, it is not testing them for AIDS. That would be a doctor's diagnosis. And people don't die of AIDS either. They die of some complications from having HIV. And I hate the term full-blown AIDS that used to be around in the 80s especially. You either have it or you don't. And so it isn't that you're full-blown. And then number of infections. It's nice to say number diagnosed with or number of acquisitions. Became infected, the same thing. That word infected sounds, not so gentle. So you can say they contracted it or they acquired it or they were diagnosed with it. So you can see some of these. And then, of course, dirty needles and clean needles. It's better to say new syringes, used syringes, that kind of thing. So just something to think about, so that we're not causing more stigma for patients that may have been using needles. And then this, I don't have the 2024 one yet, but this is the one that I have, and it shows that the number of people living with HIV that have already been diagnosed are on here. And so you can see that there were 3,411 people living with HIV who've been diagnosed. And then you can see that most of them are in those areas that are kind of green on the map. 44% of them are in the urban areas, and 30% alone are Polk County. So that accounts for 74% of them. But then you look at the rural areas, all that gray area is the rural area, and that's 26% of the cases. So sometimes people will tell me, well, we don't have it in our community. Well, maybe not, but it's in the rural communities, and we just need to continue to find people and not be afraid to ask people for a test. So there's just some more data there. And then every state has a continuum of care. So what we're looking at is where we want to get to. So we look at PL-HIV as people living with HIV. And the CDC estimates that there's 3,954 people in Iowa living with HIV. They use mathematical modeling and historical data, and so it's pretty accurate. And then of those, 3,440 have already been diagnosed. But that's only 87% were diagnosed, so that leaves still people we need to find. And then of those people that were diagnosed and received care, 88% received care. So it starts to drop down. People that got retained in care drops down to 85%. Why do you think they're not retained in care? Why don't they come back?
Stigma.
Stigma? Anything else? Like any disease, maybe there's some denial, maybe there's some other things going on with HIV. Maybe they're also using drugs or have some mental health issues. Maybe they just don't want to deal with it right now. They have other priorities. They're trying to find a place to live rather than worrying about their medical care. So we really want to increase those numbers. And then virally suppressed, have you heard of that? It's when somebody reaches undetectable, but we like virally suppressed better, because if you tell somebody they're undetectable, it's gone. They think it's gone, right? So 88% of the 112 people newly diagnosed in 2024 were linked to care within a month. And we actually just had a bureau meeting, and the CDC puts out a notice for all the states of where we're at with all of these things. And we've been #1 in the nation for a long time here in Iowa for viral suppression. So the average in the United States is like 60-some% are virally suppressed if you take all of the people in the country. And so 83% viral suppression is really high, and that's why we're #1, and that's exciting, but we do want to increase that also and have more people virally suppressed. So have you heard of U equals U? Raise your hand if you've heard of U equals U. Okay, so undetectable equals untransmittable. So this has been science for quite a while now, that, we used to think that, it was never going to go away, that you were always going to be infected and be able to transmit the virus. So now we're seeing that before antiretroviral therapy, so ART stands for antiretroviral therapy, you might have quite a bit of the virus in a container of blood, right, in a tube of blood. But after you've taken your medications, it gets down to a really low level. We call that undetectable or virally suppressed. They're not transmitting the virus. So it's really important to make sure they stay on their meds and keep virally suppressed, because they're not transmitting the virus to their sexual partners. This is one way, when I talked about stopping HIV, that's one way we're doing it, is to get people that are living with HIV on their meds, keep them on their meds. So if somebody would come into your center and say, I just moved here, or I just got diagnosed with HIV, you know, making sure that they're on their meds and staying on their meds would be important. So it's the best way we know to really contain it so that people stay healthy. They're not going to move on to AIDS and get really sick, and also so the community stays healthy so that they're not transmitting. And then have you heard of the Ryan White programs that help people living with HIV? No. Okay. So and you don't have to be a U.S. citizen. You don't have to be documented in order to get this help. So in 1990, Congress enacted the Ryan White Care Act to really help individuals and make sure that even if you're uninsured, you could get your medications. And why do we want to make sure they get their medications? To achieve undetectable, that's right. And so we have various programs in the state. One is the Ryan White Part B, and so Iowa HHS is the recipient of that. And it's like wraparound insurance. So maybe you have insurance, but the copays are pretty high. So that would help with that. Or maybe you just moved here and you don't have your medication and you just need medication for a month until you get back on your insurance or whatever different reasons. It's cheaper to get them on their medication, you know, pay for this and have them be virally suppressed than to have them get sick and be in the hospital or transmit to somebody. And then you look at some of the benefits of being in case management, because the Part B also has case management, the Ryan White program. And most of you probably realize that somebody in case management is going to do better than somebody who's not, because you're going to have somebody looking out for you and caring about you. And so you look at people that were in case management, 91% of those in case management were virally suppressed. The reason our number goes down to 83% is because some of those folks are not in case management, and they're only at 71% viral suppression, so only 71% of them are virally suppressed. So case management does help. It does work. Somebody cares about you. And then looking at U.S. born, on that very left side is U.S. born Black African American, and you can see the difference there. Those that are not in care are only 59% viral suppression. But look at the non-U.S. born Black African, you know, then it's 46%. If they're not in case management, only 46% are virally suppressed. So it's really good for them to get into care. There's just a lot of reasons, cultural reasons, or fear of doctors, or whatever reasons, but trying to find them. And we're working on this to make sure that we can reach all these populations. The same for U.S. born Latino. It's much better rates if they're in care, 92%. And then those who are not in case management, you can see the non-U.S. born, they're only 35% viral suppression. So they can still transmit if they have sex with a partner. So it's really important to take care of them and get them into care. These are just some of the services that are offered. There's all kinds of things here. The services just to help somebody to stay in care. Maybe they need a support group. Maybe they just need some transportation to get to the doctor. Those sorts of things. And this is where the Ryan White Part B agencies are. So the closest one to you would be in Omaha. And then you'll have these slides so you'll be able to see where those agencies are at. Should you have somebody who comes in here and says, oh, I'm moving to this place, then you'd be able to inform them of where they could get some care. And then there's also Ryan White Part C, and that's the providers. So the doctors and providers that are taking care of the patients, treating them and diagnosing them. And these are the places where that's taking place, where we have HIV providers who have been through the Academy of HIV training or anything else like that, where they can take care of patients. And Sonoma Community Health Center is where I managed the HIV program for over 20 years. So, is there a pill to prevent HIV? Raise your hand if you think there is. There isn't? Okay. So I don't know if you've ever seen anything on television about PrEP. Does that ring a bell? Pre-exposure prophylaxis? Okay, so it is a biomedical intervention. The person takes their medication. We have daily medication, but we also have injectable now. Makes it a lot easier for some people that don't want to take a pill every day. So we have a couple of different ways we can end HIV. I talked about getting people that are living with HIV on their pills and staying on their pills. And then if you get the folks that are at risk and you get them on meds, they can't acquire it, the others can't transmit it, we start to come to the end. And this is what we're working towards in this country. And it is working better in states that have a lot of PrEP uptake. We have a lot of folks in Iowa who are on PrEP, but we want to get more. There's populations that just should be on it and aren't, for some reason, they're not accessing it. So it's one of the reasons I go out and talk to medical offices and hospitals, is to let you know that, if somebody says something like, I had 14 partners last week, would that put me at risk for anything? Or anything that they might say about sex, ask them if they know about the pill to prevent HIV. And actually the CDC says that anybody who's sexually active should be informed that there is a pill. It doesn't mean they have to take it. And I would love to come back and talk to medical providers. Do we have any providers in here? Nurses? Just nurses? Or whatever. What do we have? Are you nurses? Nurses? Okay. What are you?
Patient advocate.
Patient advocate. Good. That would be a great thing for you to be able to inform people. If somebody would say something to you, it'd be great to say, this is something you can talk to your provider about. Did you know there's a pill to prevent HIV? Why not? Non-judgmental. Meet people where they're at. Take the pill. You don't have to take this forever. You would take it while you're at risk. So if you've got several partners right now, maybe you don't even know who these partners are, maybe they're anonymous, that's okay. Take the pill. Next week, next month, 6 months from now, a year from now, maybe you're not at risk, you don't have to keep taking it. Where people living with HIV, they need to stay on their meds. But if they're taking this for pre-exposure, to not get HIV and not acquire it, then they don't have to be on it forever. Make sense? So it is greater than 90% effective in preventing it. It's not going to prevent pregnancy though, so people would still need to use some protection for pregnancy. And then, it doesn't cure HIV. And so you may have on TV, maybe like if you're watching some of the Hulu or Netflix, you might see Truvada. That was the first one that came out. It actually came out in 2012. And so you can see that not everyone knows about it. You folks didn't hear about it. And so it came out in 2012, and it's been a game changer for HIV. We no longer have to be so afraid of it, And then Apertude is the one that's the injectable. And it's every other month. And I actually have whole slides on PrEP that I could come in and talk to the providers about if they have any questions about it. We could get them set up to prescribe PrEP, because it's very easy to prescribe. And then NPEP. Who's heard of NPEP? Anybody? I know Jenny has. Probably somewhere in the back of the room. Okay, so NPEP, we talked about PrEP, pre-exposure. You have to take the pill first. So NPEP is taking it after. So you've had sex, the condom broke, or you're not sure if that person's living with HIV. So you show up in the emergency room and say, I want that pill that will prevent the transmission. Within 72 hours is the best time to do it. Faster, sooner the better. So if somebody finds out Friday night the condom broke and I'm scared, Saturday morning you show up in the ER and ask for NPEP. NPEP stands for non-occupational PEP. As nurses, you've probably heard you might get an accidental finger stick, and from a patient, if you don't know the source of the patient, you might want to find out if they have HIV or hepatitis or blood-borne disease so that you can take care of yourself. But this is non-occupational. So these are patients who want to get a pill. Now, if they come in an emergency room and they want NPEP, that's fine. Then, 6 weeks from now they come in and they want NPEP again. That's the time they need to just get on PrEP. Just take a pill every day. Any questions about that? And you can get more information on prepiowa.org. There's tons of information out there for providers and also for individuals. And so, if you have somebody that wants to get on it and you don't know what to do, we also have a PrEP navigator. And he's awesome at helping people get on the PrEP as well, PrEP or NPEP. He's awesome at helping people, because it is insured. I mean, the insurance covers PrEP, but if somebody says, oh, something happened and I couldn't get it at the pharmacy, the prices were too high, either get a hold of me, my cards are back there, also I'll have my name at the end, but we do have, the navigator is on prepiowa.org. So. Now this is brand new. This is the first time that I've been able to show it to you because we have rules and policies about putting things out until we're sure. And this actually came out, DoxyPep. Have you heard of this? Raise your hand if you've heard of DoxyPep. Have you heard of doxycycline? Yeah. Okay, so this is a new way to use doxycycline. You know, it can be used to treat a lot of different bacterial infections. But this is to take it before. So somebody who's having a lot of sex could be on DoxyPep. Either they could take 200 milligrams within 24 hours, but again, no later than 72 hours of condomless sex, so they didn't use a condom. They're kind of worried they might get an STI. They could take doxycycline. Now, if there's somebody that's having a lot of sex, don't know who their partners are, not sure if they have any STIs, they can get on it and they can take it every day. It can be taken daily, but no more than 200 milligrams in a 24-hour period. So they can get a prescription for it. The CDC recommends really that we counsel everybody that's gay, bisexual, or other men who have sex with men, transgender women, so they were born male, and we should be counseling them on their history, see if they've ever had an STI, and if they've ever had a bacterial STI, and then also counseling them about the harms of doxycycline. So you wouldn't want to be on it more than 8 weeks. If they are more than 8 weeks, then they've got to be followed because they could have some complications. One of the things, I wrote it down to remember it, is that it could facilitate the antimicrobial risk of resistance if they're taking it more than 8 weeks. So that would be something the doctor would have to look at. So offering it is a shared decision, to talk about it if the patient wants to do this. It's one way because we've had so much syphilis, like I said, this is one thing that could really help somebody not to acquire syphilis. And so the reason that this came out and that the CDC is recommending this is to really stop gonorrhea, chlamydia, syphilis, the bacterial STIs. Is that interesting? Yeah. So good stuff that's happening to really help people. And so, you can read the script tracker. It's available to be given multiple bottles, so it's not something you can just take one bottle home. You can take more than that, then you don't have to keep coming back. And we are working on a fact sheet, so as soon as I have that, I will pass that on to Haley as well, so she can get that in her hands, the fact sheet. Pass this information along to the providers, please. Okay, so who should be screened? Well, we look at, the CDC says everybody between ages of 18 and 64 should be screened at least once in their life. Only way to find out, right? But then looking at people that might be at higher risk could be men who have sex with men, or if people have injected drugs, if they've ever tested positive for an STI, or they've had sex without a condom or without PrEP, pre-exposure prophylaxis, or if they've ever exchanged sex for drugs or housing or food or whatever else, that sort of thing. They would be the high-risk ones. And of course, pregnant women should be screened. And then let's look at some stats. So we've got the stats here. I added the 2024 stats at the bottom. You can see that our annual diagnosis, we're low in some states, so we don't have huge numbers. But in 2016, it spiked to the most ever. We had 136 diagnoses. That was the most we'd ever had. And then it went down to really pretty low in 2019 and 2020. Yeah, that's COVID. A lot of people didn't come in and get tested because they didn't even want to go to a doctor's office during that time. And then we were kind of concerned because it went back up in 2023, 139 cases diagnosed that year. That was the most ever in our state since the epidemic began. But now, as you can see, I put at the very bottom, in 2024 we had 112. So we're going back down, hopefully, and that's always a good sign. So we're finding the people, and we want to find the people, but we're hoping that less and less people will acquire it. And then this is just to show AIDS deaths, people that, developed AIDS, those numbers, what's happening with those. You can see that blue line, the AIDS diagnosis kind of goes up and down. And then that black line at the top is HIV diagnosis. So, like I just showed you, that goes up and down. And then the deaths sometimes goes down, but they're kind of on the rise again. And then this is, we don't have any newer data on this, but I show it just to show the importance of getting tested early. With any disease, it's best to be tested early because we can do something about it. And so in the early days, in the 2000s, you can see more than half of the people that were diagnosed with HIV got diagnosed late. That means they already had AIDS within 3 months of their diagnosis. So they waited a really long time until they got sick, and then they got tested. And then you can see through time, we kind of still stayed at that 50%, and we were one of the worst in the nation for that. We needed people to come in and get tested. And so that did drop down, and we're hoping that it's even dropped down further than that now. And it shows that we really, really, really need to get people tested early because we don't want them to get sick. And then we used to have the 15 to 24 age group was really kind of going up, and now that age group is going down, but you can see the 25 to 44 and the over the 45 group, that pink arrow is the over 45 group, and then the one with the little blocks in it is the 25 to 44, so those numbers are still increasing. And I think this one's interesting. You look at population. So you see Hispanics represent 7% of the population in Iowa, yet they represent 19% of the cases of AIDS, of HIV. And then you look at black represent only 4% of the population in Iowa, why do they represent 32% of the cases? So it's something that Health and Human Services are working on to try to figure out ways to reach those populations and really help with the disparities. Any questions so far? Okay, and I'm not going to talk a lot about STIs because I came to talk about HIV, but like I said, you need to make sure that we're working with STIs because HIV is an STI as well, and until we can really impact STIs, we're not going to eliminate HIV either. So just for a quick minute here to talk about sexually active women who are younger than 25 should be screened annually, even if they don't have any signs and symptoms, because that's where our numbers are. For gonorrhea and chlamydia, it's 15 to 20 something, 24. That's the age group that primarily have gonorrhea and chlamydia. And then if they're older than 25, but have any of these risks, like you can see, if they've got multiple partners or a new partner, or they've had an STI in the past, that sort of thing, they should be offered a test as well. So even if they don't come in for that reason, but to be talking to people about it. And then for men, you're looking at the people that are at a high burden of disease, those should be tested. So especially sexually active gay men or men who have sex with men. What's the difference between gay men and men who have sex with men, do you know? We use this in all of our data, men having sex with men, because it's inclusive of everybody. They might be bisexual, they might have sex with a woman, they might be married to a woman and have sex with a man. So it includes everybody that's a man having sex with men. And if it's in a high prevalence area, like in Polk County, that would be a high prevalence area. In Omaha area would be a high prevalence area for men having sex with men. And then for syphilis, pregnant women need to be screened at the first trimester, then at 28 to 32 weeks, and then again at delivery for syphilis. It's the only way we're going to really get rid of the syphilis. I talked about this when I came in a couple months ago. Even if they don't have any signs and symptoms, we need to be testing them. And then, of course, the same thing for men as far as what we talked about with the other STIs. If they're a part of a population with high burden of disease, we should be testing them. Pregnant women, the same thing. And then just to look at this, so in 2023, there were 943 cases of syphilis in the state. And if you go back to about 2020, there were 500 cases. And the year before that, there were 250. So it had doubled. And now, here we are 5 years later. In 2024, we had 1,026 cases reported. So it's not going away. It just keeps going up. Chlamydia and gonorrhea have decreased, but syphilis keeps increasing. And the number of cases among women more than quadrupled in 2 years. So it isn't just men. And then you can just see the ages there. It's all over the place. A lot in that 25 to 39-ish, but it's all over, all the ages. And then congenital syphilis. So just mentioning that, like I did when I came in to talk about syphilis a couple months ago, you look at, we used to have 0 cases of congenital syphilis in the state, which is ideal. And then pretty soon we had 11 cases in 2021, more than the last 20 years combined. And then it went down a little bit, and then 13 cases, and then 19 cases in 2024. We want to go down, we don't want to keep increasing. And so one of the things that we've done in my county, Woodbury County, at the WIC office, they are asking every woman that comes through for WIC resources if they've been to a medical provider for their pregnancy. And they're finding that they found between January and May of this year that 31% hadn't seen a doctor. And so they were sending them to the STI clinic nurse to talk about the importance and why it's important and what can, we can avoid getting, having the baby acquire syphilis and things like that, and making sure that they have vitamins they need and all that. So I think that's going to be a really good start to try to encourage women. There's all kinds of cultural reasons why maybe you don't show up until birth in your own country, but here we do it differently. So we just need to be cognizant of the fact that some women aren't coming to the doctor, and it would be good to try to get them in, get them tested. And then, like I said a couple of times, if we can't impact STIs, we're not going to get rid of HIV either. And so this just shows that, it's the only one I have for 2020, but it shows that when people got tested for HIV, within 30 days of their diagnosis, they also had another illness. So 8% of them also tested positive for chlamydia. 10% of them also, besides HIV, tested positive for gonorrhea. 7% of them tested for late-stage syphilis, so that already progressed. And 12% of them tested positive for infectious syphilis, so it's transmissible at that point. So not only HIV diagnosis, but within 30 days, a lot of people had another diagnosis as well. So that's why it's good to test everybody. If somebody comes in and says, I'd really like to get a test for gonorrhea, because I heard about that, test them for gonorrhea, chlamydia, syphilis, HIV. The treatment guidelines are there, so if providers ask you, or you need to know what is the treatment, it's easy to have the app. And none of the testing can happen if we're not doing sexual health assessments. And so I know that doctors and providers and nurses are all pushed to do more and more. Now you have some more patients in your schedule today that you didn't know about because they got sick, and you get so many people in that you don't have time to talk to people about everything. But if we don't talk about their sexual health, we don't know who needs to get tested. And patients are afraid to bring up sexual health. People are afraid to come in and say, I injected drugs, or I had 14 partners last week. And so it can be hard for them to start the conversation. So we have lots of ways that we talk about. I like this one where, have you been sexually active in the last year? And if yes, okay, what kind of sex did you have? Oral, anal, vaginal? Just asking, I ask all my patients this kind of thing. And then, how many partners have you had? Because if they've had 12, it's different than having one. And so maybe you could do an STI test today. And it's really quick. If you haven't been sexually active, just continue with what you're doing. One thing that I've said, that sometimes providers will ask me, well, how do I start the conversation? Because I don't want to offend my patients by, you look like somebody that could be talked to about your sexual. They don't want to offend them. And so here's one thing that I've come up with, and I've run it by some people living with HIV, and they thought it was a good concept to start with. So I say, let's say the patient's name is Johnny. Okay, Johnny, we've talked about your medical care, and we're in a good place. We've talked about your mental health, things are working out. It's going well. What we haven't talked about is your sexual health. Could this be today that we start that conversation? You're asking permission, and you could also preface it with, I ask all of my patients this, I don't think we've talked about your sexual health. Could we start that talk today? Now, it's a really quick conversation if the person says, I've been with this guy for 35 years and everything's fine, I'm just worried about my thyroid. Okay, you planted the seed. You had the conversation, this is the place you can come to. But it's the one person that says, I had 14 partners last week, would that put me at risk for anything? Now you can talk. Now you say, let's talk about STIs, let's talk about getting an HIV test, that sort of thing. How about getting on PrEP? Have you heard of PrEP, the pill to prevent HIV? So unless we're having these conversations, we're not going to get at it and find out what's going on with somebody. And I know we don't have time to talk to every single person about it, but you'll know the right time to try to bring it up. And even, like I said, to say, does anyone talk to you about your sexual health? Because I think that'd be an important topic to talk about. You'd be surprised then. And so we can talk about all these different P's, partners, Who are your partners? What kind of sex do you have? So your practices. Oral sex, anal sex, vaginal sex, because we'll talk in a minute about if they're having oral or anal sex, what we might be able to do. So protection is another P. What do you use for protection? Pregnancy. Are you hoping for a pregnancy? Are you trying for a pregnancy? Or are you hoping not to get pregnant? How are you protecting yourself? And then any past history. And then also thinking about pleasure. People want to have sex for pleasure. And if it's not pleasurable, if something's not functioning right, then maybe they need a conversation as well, but maybe they're afraid to say that. So they might have been having some problems. Or they might have some pride. They don't want to tell you their gender identity. And so just starting those conversations, you'd be surprised people feel really relieved if the provider brings it up. There's been some studies done that show, and we even had some in Iowa where we did a needs assessment and looked at some of the questions around, stigma, and people didn't want to come in and ask. They wanted their provider to bring up sex, or the nurses. And so I said, one of the reasons asking them if they've had anal or oral sex is because we can do extragenital testing. Do you know if you do extragenital testing here? So that would be testing for chlamydia and gonorrhea at any body site other than the urethra, vagina, or cervix. And so you're going to have to do a swab of the mouth or a swab of the rectum. And why is it important? Well, look, it says testing for chlamydia and gonorrhea for only urine specimens misses 70 to 88% of infections in men who have sex with men. You're missing it. And rectal gonorrhea infections are asymptomatic 85% of the time. So you just have to routine screen because no one's going to come in and say they have this symptom. And even among women, 30% of gonococcal infections and 14% of chlamydial infections would have been missed if they're only doing urogenital testing. And rectal infection is linked to an increased chance of HIV acquisition. And infections in the throat, they're saying, may be an important site for the development of drug-resistant gonorrhea. So asking patients can feel, invasive, but you can always preface it with, because of the fact we can do different testing, I'd like to ask you if you've ever had oral or anal sex. And, you can tell by their reactions sometimes some people are going to say, ooh, now. We only ask you because we have some testing that we can do and it wouldn't show up in a urine test. And patients don't know that. They think if they come into the ER for something, that you're testing them for everything. Extragenital testing. So you can find out if that's something that you can do here. Here's your assignment. And so then, just to let you know, the Iowa law requires both the provider and the lab to report to Health and Human Services if it's HIV diagnosis for a newly diagnosed person, or even if they've been previously diagnosed but they just moved here, or they're the provider, we need to know who those people are so we can see if we have them tracked anywhere, and if there's any children born to a positive woman, we'd like to say a person living with HIV. And then hepatitis C, you would have to report the screening results if they're positive, but then if you get the confirmatory test, they want to know if it was positive, reactive, or negative, not detected. They want to know because you sent in the screening. And then STDs, of course, the ones that are required are chlamydia, gonorrhea, and syphilis. Those are the ones that are required to report. That's a map of all the disease intervention specialists in the state, and it changes frequently because sometimes people leave, we get a new one. But if you need a disease intervention specialist, Lacey, last time I was here and I talked about syphilis, Lacey was on the line with me. We did a co-presentation, and it was hybrid, so she was on Zoom. And so if you would need anything, your provider or a patient says something and you're not sure, what is the treatment for this STI, or what happens because of this unusual thing, we don't know what to do. For STIs or HIV, we got a newly diagnosed, we don't know what to do, start here, talk to Lacey. She's awesome, and she will help you out. We do have our condom distribution efforts, so any agency can get condoms distributed to them, and so it's nice to have them because if they're available and accessible, people will more likely use them than if they have to go and ask for them and they're behind the counter, or they're locked up, or you're in a small community and they're behind the counter. It's like Sudafed. You have to ask for it, and then you feel like you're a drug user because you have to ask for Sudafed. So you go in there saying, I need my Sudafed, see, I'm really sick. Because you're embarrassed sometimes to ask for the Sudafed behind the counter. Well, imagine a 16-year-old who's having sex and wants to use a condom, but they have to go in, and maybe Aunt Mary's working at the pharmacy, and so they're with that idea. So even individuals can get access to our condoms. So it's at myiacondoms.org. And I know that Summer from Public Health, sitting back there in the corner, she orders them. And so if you need new condoms, I think somebody from here is ordering. I think I asked a couple months ago and somebody is ordering. So it's good to have them. If not, let me know. We'll figure out a way for you to get them. And so ways that you can help then is to help us, get case finding. So sexual health assessments are important in order to find out who might need a test and how to get people linked to care. Now you know that there's some Ryan White resources out there, and if you forget, it's in this PowerPoint. You'll have that copy because Haley can send that out to you, but also you can always call me. And so using your resources, I can be your connection. If you have a question I don't know the answer to, I know just where to get it. And you can help address and combat stigma as well by not being judgmental, by helping people out to feel welcome to come in and talk about these things. And so I have one last question here. What is the weight of stigma? And I want you to think about it for a second. I actually have this rock, and I may have brought it with me. Okay, do you have it? So a patient made me this. A patient living with HIV made me this. And sometimes I just like to pass it around. Just pass it around. Just look at it. What do you think she meant by this? I like to say, heavy. Stigma's heavy, right? So what do you think the weight of stigma is? What would your answer be to that? Anybody have any ideas? What does stigma do?
It's people from getting treated.
Sure. Prevent people from getting treatment. Might be afraid to walk through the doors. Anything else? So my answer to that, I think the weight of stigma is, I think nothing weighs more than someone who believes in you. Nothing weighs more than someone who believes in you. And that's why people that are case managed do better, because they've got somebody who believes in them. And I actually talked to Haley and asked if I could come back with a colleague from Zion, who is Amanda Whaler, and we both have some talk on stigma that's really kind of fun, and we think that that would be a great thing to talk about as well. So this is sort of a teaser, is we could talk more about stigma. But I also, and I'll take any questions, but I want to give a chance for Jenny from Potawatomi County, who's also one of our testing counselors in the state. If you want to come up here and talk about what you do, because she's got testing in this county. And then I'll take any questions. And then also, if you didn't want to fill out the paper form, there's a QR code there too. So I'll let you talk about what you offer.
Okay. So hi, I'm Jenny. I'm with Potawatomi County Public Health. And Montgomery County is one of our counties. So just because we're Pot County, we have surrounding counties. We have Mills, Montgomery, Fremont, Union, Decatur, and Clark counties. And what I do and my other nurse partners is we come out and we provide testing in these counties. Because some people don't have insurance, our testing is free. We have a grant from the state. It's a SPOTS grant, and they allow us to test for chlamydia, gonorrhea, HIV, syphilis, hepatitis C for free. And if anybody happens to test positive, we also treat for free. There's no age limit. We can test from 15 to 90, whatever the ages are. And I have partnered with Summer at the Public Health Office to come down and provide testing by appointment only. I used to come every month, but I would sit there for 2 to 3 hours and nobody would come in the office. So now we offer it per month, by appointments only. I do go to the Fremont County or the Montgomery County Jail, and I offer testing there too. I do have a little pamphlet here. It talks about if somebody wants to come up to the office, which I know is about a 52-minute drive from here, but we are open Monday through Friday, 8 to 4:30. We provide all of the testing, treatment there. We can get you prep. We work with the same navigator that Darla works with. He is absolutely wonderful. He is bilingual. He speaks in English and in Spanish. He will text, he will call, he will do whatever it takes to get somebody on prep. We do have DoxyPep on hand that we can prescribe. We work under standing orders, so as a nurse, we can still give out DoxyPep if anybody would want it. We provide condoms. We have female condoms, male condoms. We have dental dam, we have lube, anything that you guys might need or somebody might need, that's what we do. So if you guys want to take a flyer, so if you guys get a patient that doesn't have health insurance that walks through the door and they're like, well, we really need this testing, but we can't afford it. Or, you know, the chlamydia treatment, you know, azithromycin or doxycycline is too expensive. They can come see us, or I can come down and go ahead and treat them.
Pretty exciting.
It is. It's very exciting. And then we work with NAP, which was on that Ryan White program, to make sure that anybody that is diagnosed with HIV gets the help they need. You know, they provide rides, they can help with rent, they can help with electricity, food, anything that might put somebody living with HIV in a predicament, NAP can help with.
Nebraska AIDS Project.
Nebraska AIDS Project, yes. And then if you have anything else, if I don't have an answer, I find it.
Yeah.
So, any questions?
For either one of us?
Thank you for your time today. It was nice to educate, and hopefully if you guys have somebody come in, you'll think about us.
Yeah, get that word out into the community, because people may be afraid to come to the provider and ask, right, or talk about it at a nurse visit, but if they find out that this is available, it might get to be a more popular thing to do, is to come in all by yourself into public health, which is a lot less intimidating maybe than bringing it up at a doctor visit when you're there for something else and then saying, by the way, I also want to talk about this.
And going into the public health office, they don't know why they're coming in there. You know, they could be coming in there for immunizations. They could be coming in there just because they have a question. Maternal health is in there. So it's less stigmatizing than if I was to do a pop-up testing at, I don't know, a county fair. You know, then they know why they're talking to me, because that's what we do. So,
And people, if they don't want to come to our local public health because of stigma and they do have transportation, they can go to Pot County and see you.
yep, and we do walk-ins. Monday all day we have walk-ins, so no appointment is needed. And then Thursday afternoons, we do walk-ins from 1 to, we take our last person about 3:30. The second Saturday of every month, we're there from 8 to noon. And then the fourth Thursday, we're there till 6. So it kind of helps people who have jobs get in and get seen.
And there's testing counselors like Jenny all over the state, so if somebody would say, yeah, but I really live in Des Moines, or I really live in Dubuque or Cedar Rapids, we can get you that information too as to where they would go for that, because a lot of people around the state are doing the outreach testing to try to be there for people.
They want us to go where they're at, meet them where they're at, because it seems like it's easier, less stigmatizing, and not that, you know, people are afraid to bring it up to their doctor, but, you know, sometimes they're afraid that they're going to be judged. And if they come to us, you know, that's all we do. So we try to be less stigmatizing than anything, so people will come in and get tested and treated.
So what questions do you have about NPEP or PrEP or anything that either one of us talked about? Questions? Did you learn anything? Learned a couple things? Yeah? Do you have any questions for public health? Because we have summer here. Anything you ever wanted to know about public health? Well, thank you, Haley, for having us come in. And I'm glad that we had Jenny be able to let you guys know what she's doing too in the community and how you can reach out to any of us. No wrong door, we always say.
Yep.
So if you ask a question and one of us doesn't know, we'll find out the answer for you. So feel free to contact any one of us.
Yep, and if you forget who I am, Darla knows how to get a hold of me.